APSA asked us to combine two concepts. The first was a break shop on Feto, and the second was a break shop on the management of severe CDH. And they asked us to merge that into one in 45 minutes. Obviously, that's a daunting task. The way this format is going to go is first we're going to have Tim Lee give us a brief overview of Feto in North America, focusing on North America. There's some recent publications that we need to review and perhaps think about what are next steps. There won't be time for question and answer discussing Feto because that would take hours. And then we're going to hear two case presentations. They're going to be brief presentations, but they're going to allow us to launch into discussion of some general concepts on the management of the severe CDH patient. The original purpose was mostly to hear from expert panelists here. Unfortunately, Holly Hedrick couldn't make it today due to a family illness, and Sean Kunisaki's plane was delayed, so apparently he's arriving at 7 and unfortunately is missing our symposium. But we have a great group of panelists. Ina Lobeck is from University of Wisconsin in Madison. DeSola, I can't pronounce her last, Adin Kunle is from UNC. Augusto Zani from Toronto, as you may know, is sort of the center of CDH management in Canada. George Mihalishka from University of Michigan. Tim Lee, of course, is from Texas Children's, and I'll serve as moderator. So without further ado, let's start with Tim's presentation. Thank you.
Hey everybody, my name's Tim Lee. I'm from Texas Children's Hospital, and the committee asked me to give just an update on fetotracheal occlusion. So let's get this party started. So I have no disclosures. The way I thought I'd do the outlines, let's talk about some of the current studies that are out there right now on Feto. And then we can just go through some of the inclusion and exclusion criteria for Feto, like how are we selecting these babies that are getting this fetal intervention. The second is to look at what current centers are performing Feto in North America. And then finally, let's talk a little bit about maybe what the future of fetotracheal occlusion may look like in North America. So first, we should talk about this paper that came out in the New England Journal of Medicine. It was out of Europe. It's called the TOTAL trial. And this is the first randomized controlled trial that was done on tracheal occlusion. That 10 Feto centers in Europe and 26 neonatal care centers. That 80 total patients, 40 in each arm. There was a intervention arm, and there was kind of an expectant management arm that did not get the balloon. And finally, balloon placement was performed between 27 to 29 weeks gestation, because that's when they thought they could see the most lung growth. So what did they find? Well, when you look here, when you look at the survival, you can see that in the Feto arm, it was 40%, and in the expectant management arm, it was 15%. It's pretty similar, surviving to 6 months. And then the next thing that you see here is that the complications, right? Preterm labor was significantly higher in the Feto arm, and significantly higher in preterm birth in the Feto arm. So I know what you're saying is you're looking at this mortality data and you're like, wait a minute. My center compared to these guys, man, we crush it compared to them, right? Like this just doesn't really make sense maybe in North America. And I think that is one of the limitations of the study, is that when you really look at the study, they had very low ECMO use amongst the centers. Even in the expectant management arm, the arm that didn't get tracheal occlusion, ECMO was only used 29% for babies that ended up dying. No standardized postnatal treatment algorithm. The way they did it in Europe was they would get their balloon placed at one of the 10 centers, the balloon removed at one of the 10 centers, and then they would go back to the center that was referred. So the question is this really applicable in North America? And it's interesting because we just had Jan de Press, the lead author of the study, that came as our visiting professor a few days ago. And basically I asked him the question, I was like, hey, Yannick, is this really applicable? And he said, in Europe, mortality is the outcome that we're interested in. In North America, maybe you need to look at a different outcome. versus mortality, because clearly your survival is better. Is there another primary outcome where Feto may be of benefit? So here is then our North American study. This is the largest one that was a compilation of survey data that was inputted into the North American Fetal Network. And basically what it did is data collected over this 12-year period at 10 NAFNet centers that were doing tracheal occlusion. The analysis was exactly the same as for the trial in Europe, meaning the severity was the same and how they defined the patients. And what you'll see here on this slide, the stuff highlighted in red, is that the survival for the tracheal occlusion patients versus the expectant management patients was really no differently. Statistically, it wasn't different, maybe a little bit higher. And then when you look at ECMO use, the ECMO use wasn't really statistically significantly any lower, as well as duration of ECMO, even though it kind of trended toward significance. But when they broke out a subgroup analysis of the most severe cohort, this is all recorded, observed to expected lung head ratios less than 25, obtained before 30 weeks in gestation, early in gestation, as well as balloon placed in that same interim period where we think they're going to get good lung growth. What you see here is that actually the duration of ECMO that the patients were on fell out as being significant, almost in half. And maybe that's what Dr. DePress was talking about, is that is there a role for Feto in something that may not be purely related to mortality? So right now, when you look at tracheal occlusion in North America, I just pulled these inclusion criteria off of clinicaltrials.gov. You can see that centers are starting to use it. And what you see here is that the reason for the studies are all changing a little bit. Like if you look at our study, we've already done our safety and efficacy study. So we're now looking at the effect on pulmonary hypertension. If you look at the Children's Hospital for the CHOP study, they're still looking at successful balloon placement and removal as their primary outcome. And then the Cincinnati study is looking at change in lung growth in their patient population. When we look at exclusion criteria, though, this tends to be a little bit more standardized, and it's pretty standard for any type of fetal operation. You see multiple fetal pregnancies, uterine anomalies that predispose to complications, shortened cervix that would make it more likely for preterm labor, history of preterm labor, fetal aneuploidy, maternal BMI greater than 40, and an allergy to latex. And the reason for maternal BMI greater than 40 is that the length of the trocars in the instrumentation, sometimes if the body wall is too thick, you may be able to put the balloon in, but then after they gain weight through the rest of the pregnancy, you may have a hard time getting that balloon out. So that would be a problem. And now when we look at the fetal centers in North America that are performing Feto, I just pulled this off of clinicaltrials.gov for the centers that are actively recruiting patients. And you can see that there are a number of centers across the country that are doing it, from the West Coast all the way to the East Coast. Pretty much in almost every region of the country is doing it now. So if you're not a Feto, if you don't have Feto in your center that you work at, this would be a geographical map of where, if you were to refer a patient for something, that it would be able to go. And this is just off clinicaltrials.gov. So finally, I just wanted to talk about the future of fetal tracheal occlusion. And this is, when you think about it, well, how can we improve the safety and availability of Feto for patients that at least may want to be considered for the operation? And I think when you know, if working at a fetal center, many of our patients travel from great distances. Sometimes they may be limited by socioeconomic status on whether they can stay at the fetal center. Because unlike Europe, what we do is when we put the balloon and we take the balloon out, they usually stay and deliver at the center where all of that has occurred. But one of the reasons, but something new that is coming down the pipeline that's coming out of Europe, it's already in phase 1 study and is being done by Jan and his group again, is the smart tracheal balloon. And what it is you put the balloon in, but then to take the balloon out, it has a magnet valve on it. And if they walk around a 1.5 Tesla MRI, the magnet will move and the balloon will deflate. So now you've basically prevented them from getting a second procedure. And 2, if they were to, say, go back to maybe a center that wasn't the balloon center, could they have the balloon released at, say, a non-fetal center? So they've just, as Dr. DePress was talking about with us in Houston a few days ago, they've just finished the first part of their clinical trial for this, and the results are probably be coming out pretty soon, and it's pretty cool stuff. So anyways, just the final thoughts about, tracheal occlusion. You can see that fetal use is increasing across North America. Number of centers are starting to pop up. I think the one thing that we can look at here within our centers versus survival is like, are there secondary outcomes that we need to start studying, such as pulmonary hypertension being one of them when you think that, ECMO use, et cetera. Finally, focusing on the morbidity. The total trial was not powered to look for morbidity, but I think that's probably the next step when you think about this type of intervention. And finally, continue new device innovation to improve safety. So anyways, that's it. Awesome. All right.
That was perfect, Tim. Ina.
Yeah, thank you. All right, so as Daryl mentioned, this is just a very quick case presentation to use as a launching pad for further discussion and bring up some good questions. I have no disclosures. A 21-year-old G2P0 presented at 24 weeks with a diagnosis of a severe left-sided congenital diaphragmatic hernia. On ultrasound, the LHR was 0.2, OTA-ELHR was 18%, and liver was noted to be up. She had an amniocentesis with microarray sent that showed no abnormal variance, and a fetal echo that showed rightward deviation of the heart as expected without any anatomic anomalies. She was referred to our fetal center for possible tracheal occlusion, however, was found to not be a candidate because maternal BMI was 50 and the mother lived 4 hours away from the fetal center and was not able to move closer. She did have a fetal MRI that showed a left-sided CDH containing stomach, bowel, spleen, and 16% of the liver up. Her OTA-E TFLV was 18% on ripens at 24 weeks. No other congenital anomalies identified. She delivered prematurely. She did have quite significant polyhydramnios with an AFI of 35. Delivered at 33 and 0, estimated fetal weight at the time was 1.8 kilos. Initial heart rate was 60. The baby was resuscitated, intubated with a 3.0 microcuff tube, and placed on the vent with the settings of 20/4, rate of 40 and 100% FiO2 initially. With this, the heart rate improved to 100. The preductal sats at the time were about 70 to 75. Vent settings were initially increased to 25/5 to improve the oxygenation. And at 10 minutes of life, our preductal was 85%. The end tidal was 70, and the gas was as shown there. By 20 minutes of life, we had gone up on the respiratory rate gradually to 55. We had sedated and paralyzed the baby. And despite this, our blood gas was 7.08 with a CO2 of 90 now. We obtained an echo because we believed we were heading towards ECMO territory that showed normal biventricular function and suprasystemic pressures. As one last-ditch effort, we placed the baby on the oscillator and started INO. However, despite this, our blood gas was 7.02 with a CO2 of 100 now, so we decided to cannulate. We cannulated for VA ECMO with a 6 French arterial, 8 French venous. We anticoagulated with bivalve to target PTT of 70 to 90. The CDH was repaired with a patch on ECMO day 2 and with temporary abdominal closure. The baby did require subsequent CRT for pretty significant AKI while on ECMO on day of life 6, and finally, by day of life 30, came off of CRT and was shortly thereafter decannulated from ECMO. Baby underwent abdominal closure with mesh on day of life 32 and was discharged home on day of life 62.
Thanks so much. So obviously there's a ton to unpack there. But we wanted to focus our discussion just on a few points. And then DeSolo will present a different case and we'll talk about a few other things. So the first question is, when do you get echoes and what do you do with the information? There was a recent meeting where David Kays kind of described a protocol where he never gets echoes. So the question is, what do you guys do? So let me start with Tim from Texas Children's.
So we'll usually get an echo within about anywhere from 24 to 48 hours of life. If they're really getting sick, though, we'll get it sooner because we want to see what the heart is doing, what the left ventricle is doing, so we can help us make a decision about what vasopressors to use for that. From a structural standpoint, we're usually not that concerned because we know that our prenatal echoes are, pretty good. So we've never, at least I think we published a paper a few years ago where it showed that we never had a case where the prenatal echo was so off that it precluded them from being like an ECMO candidate or something like that. So we're not really looking for structural data, we're looking for functional data.
Awesome. Thank you. Augusto, Toronto, sick kids.
Yeah, more or less the same, but it's not just Toronto. I mean, I see at the back of the room Pramod Purgandla, who is actually from Montreal, that has spearheaded these Canadian guidelines. And so these are 16 centers across Canada, and we just published this year a second iteration of the guidelines. And so it's not just Toronto, but also the centers, if they follow the guidelines. And it's, again, within the first 24, 48 hours. Same talking about Toronto. We all our CDH babies get a fetal echo, so for structural anomalies we would know already in advance. But we would get the echo again to look at function and pulmonary hypertension.
So George, I'll add to it. So you get your echo at 24 hours or so. The infant's on 25/5, rate of 45, 60% oxygen, adequate blood pressure, urine output. The pH is 723. And the echo shows suprasystemic pulmonary hypertension. What do you guys do with that info?
Yeah, so I would say historically at Michigan, since the Ninos trial back in the, I think, mid-90s, we have been one of, I think, few institutions that really did not jump on the nitric bandwagon, and we very, very rarely use it pre-ECMO. So in this child, the way you describe on general ventilation settings, good gas exchange, and hemodynamics, we would just watch the child. We would not initiate nitric.
Okay. DeSola, North Carolina.
I think in this situation, we would have, we tend to have kind of more multidisciplinary type discussions, but if the child is doing fine clinically, I think that we would know that there'd be a high likelihood they would go on nitric, but not necessarily put them on if they're doing well otherwise.
Yeah. So I had a conversation with David Kays today. He unfortunately couldn't make APSA, and we were talking about having some kind of virtual element where he would participate, but that we couldn't figure out how to get that done successfully and within the framework of this design. And he interestingly says that they do get an echo immediately after birth. I have a feeling it's to confirm anatomy and to make sure there's no cardiac defects, but he does not do anything with the information that isn't about gas exchange or perfusion. So it doesn't matter what the echo shows as long as there's no congenital heart lesion. So we talked a little bit about I&O. It turns out there is a remarkable care variability here. And many neonatologists might say there's no convincing evidence about the effectiveness of I&O in this setting, and that may be true. And the question is, when do you use it? I heard some information. It sounds like we're kind of in concordance. So, Augusto, if the preductal SAT's 89 to 90% on gentle ventilation settings, and there's suprasystemic pulmonary hypertension, would you add I&O at that point? Or
So it depends if the lung is recruitable and there's a good left ventricular function. There would be an indication we might. Of course, it could be the case that we just looked at. It very much depends on. It was not so severe, so you might or you may not. But that's, I think, you need to look at, and that's where the echo is important. You want to know if your left ventricular function is okay.
Let me ask the audience, just with a show of hands, is there anybody at a center that would not use a trial of INO in the setting of CDH? Matt's going with evidence. Okay. See, there definitely is care variability here.
Well, right. I mean, if I could just add, like there were a couple hands, and there have been multiple papers published that indicate there has been for the last 2 decades widespread use of nitric in the absence of any good data on efficacy. There's, I think, some cohort studies are coming out that with certain cardiac phenotypes there may be benefit, but overall there has not been great study on efficacy, and yet widespread use.
Okay, let's talk about ECMO. It sounds like this infant was rather small and VA was likely the only option, technically. But the question is, does anybody advocate for VV ECMO in this setting? Would anybody have, well, let's say this was a term infant that was 3.6 kilos. Any of my panelists, have they started with VV ECMO? Augusto's shaking his head. Toronto and Canada, well, Toronto is a low utilizer of ECMO overall.
Yeah, that's true.
Tim, what do you think?
I think we were, I think for us, we kind of rapidly adopted VV ECMO when, the Avalon came out and we started using it in CDH. I know there were some papers that came out early, that showed the results were as, at least comparable to VA ECMO and some, smaller kind of center studies. We tend to have gone away from that a little bit. We will use pretty much almost all of VA ECMO now because at least for the severe CDHs, we just feel that they just need more support. I think the one situation we may use VV ECMO is where you have a baby that has of the mild kind of phenotype, doing okay, gets into a hypertensive crisis. You just gotta kind of support them through that crisis, almost like a PPHN kid. We may then consider using VV for that patient. But we're pretty much do VA almost all the time now. But I'd be curious to know, are there primary like VV people in here? Dr. Olatoye.
So Yinka and I at Texas Children's in the era of 01 to 2016, 17, 18-ish, I believe we managed similarly, and we were proponents of using VV as a primary modality, and if we had to convert to VA, then no problem. We could do it technically, with the argument that you're providing oxygenated blood into the pulmonary vascular bed. It's technically harder because the cannula has to be good, the position has to be good, and volume status has to be fine-tuned, and it leads a lot of work. But I'm personally rethinking it because perhaps because of the good outcomes David Kays is he promises that a manuscript will be forthcoming. And by the way, he said that they're going to do about 75 cases this last calendar year. It's an awful lot, as most of you know. He has an impact on CDH care throughout the United States. And he only uses VA ECMO. But nobody would start with a trial of VV on this infant if they were bigger and could take a 13 shin? Okay.
I'll just add, I've been to a few CDH ECMO meetings in the last few months. It's very interesting. In Europe, there's a growing big experience using 2 cannula VV, 2 8 French cannulas. And in Mannheim, for example, they have, I think their survival rate on ECMO might be 70%. It's very good. And they do 2-site VV. So I think, my bias, and at Michigan, we've historically done VA. I like the fact that in CDH babies, you can offload the right heart. Seems to make sense to me. But I think we all have sort of a bias. And VV may be equivalent. Just throwing it out there.
Lots of unanswered questions. And then how about any kind of cutoffs for use for cannulating for ECMO on a CDH infant? 34 weeks, 32 weeks, 2 kilos, 1.8 kilos. George, Michigan?
We've definitely done younger kids, and I think it's possible if infants are less than 34 weeks. I definitely tell the families, particularly in CDH, the survival is lower. The rate of ICH in Big ELSO database is about almost 20%. So it's higher, but it's not 50%. And in a CDH, we would go down around 32 weeks, maybe 1.7, 1.6, if we can get a 6 and 8 cannula in.
Ina, what about Madison?
In Madison, we have a hard stop at 34 weeks, but there's been a lot of recent debate about that.
Tim, Texas?
I mean, in Texas, we shoot first and ask questions later, right? So,
Gotcha.
no, I'm kidding. Not really. But no, we will go down, kind of like what George is describing. We'll go down as low as 32 weeks. We've actually cannulated lower than that, but those kids have had bad outcomes. So we kind of have a hard stop at 32. And based on their weight, whatever we can get a cannula in for us. So,
Quick question for the audience. How many centers have hard stops of some nature? Half-ish, maybe?
Is it 34 weeks?
What is it?
Yeah, okay. All right, let's go on to Sola.
So I'm going to be presenting about a similar patient and our management of a right CDH in a premature infant. I also have no disclosures. So this was a 35-year-old G2P0 who was initially evaluated at 24 weeks gestation for a right congenital diaphragmatic hernia. The LHR at that time was 0.8. The O to E LHR was 53%. And the O to E TFLV was 29%. This child was conceived by IVF, and parents wanted a referral for possible feto, so they were referred to a feto center and were deemed ineligible due to the LHR. The course of the pregnancy was notable for fetal IUGR. Through the entirety of the pregnancy, the estimated fetal weight was between the 7th and the 11th percentile. And the mother was admitted to the hospital for fetal monitoring. She went into spontaneous labor at 34 weeks and delivered at 34 and 1. At the time of birth, the baby weighed 1.57 kilos. They were intubated on AC, PEPA 5, with a PIP max of 22, so general ventilation. And you can see the goals listed here. We typically get an echocardiogram at the time of birth, which is notable for mild to moderate tricuspid valve regurgitation, pulmonary hypertension, with RVSP of 59. At that time, we had talked to the mom prenatally and at the time of birth about the possible candidacy for ECMO. And given the child's weight at that time, the conversation was that the baby would likely not be a candidate for ECMO, given how small they were and their premature age. The child did fine on the first day of life and then was subsequently transitioned on the second day to high flow jet ventilation for persistent hypoxemia. And at that time, we initiated nitric. The patient also had persistent hypotension and was placed on epinephrine, dopamine, milrinone infusion. By day of life 3, the child continued to have persistent evidence of pulmonary hypertension based on their echocardiogram, and so we initiated IV sildenafil. They did fine over the next week, and we were able to essentially titrate down some of their pressors, but then on day of life 10, we had a worsening hypoxemia and hypotension. Of note, at that time, the baby had grown to 1.7 kilos, and we had another conversation with the family about, just where things were from a clinical standpoint, and they elected to try to have us attempt an ECMO cannulation. The child was initially attempted through a peripheral VA ECMO cannulation. We were able to get an 8 French cannula into the right common carotid, but we're not able to get an appropriately sized cannula into the right IJ. As such, we made a consult to our cardiac surgery team during the cannulation, and they were able to centrally cannulate the baby, and the baby ended up with a 12 French right arterial cannula. 2 days after that, so on day of life 12, the child had a right CDH repair with Gore-Tex patch on ECMO, and the abdomen was closed temporarily. They were able to come off ECMO on day of life 15. So they had about a 5-day ECMO run, and the chest wall was closed at that time. The abdomen was subsequently closed, and on day of life 31, they were extubated to high-flow nasal cannula, and they were discharged home on day of life 132 with a gastrostomy tube on sildenafil and an H2 blocker.
These questions might be a little simpler. So operating on ECMO, timing, for the audience, is there anybody that won't do early repair on ECMO, like within the first 24 to 72 hours or so? Is there anybody that, what happened? Where were we? Sensitive. Thank you. Anybody not doing repair on ECMO, doing it before coming off ECMO? No. Everybody early repair? Oh. Paolo. Okay. Okay. Old school. Tim.
You do it.
Augusto, well, Tim George, early repair. Sounds like Wisconsin and North Carolina also.
Yeah, we do early repair if we're on ECMO.
So we have, I think the balance of the data supports early repair on ECMO, but of course you're balancing the risk of anticoagulation and bleeding with the potential benefit. What we've been doing at Michigan for several years now is a hybrid approach that if most of our babies we diagnose prenatally, and if they're in the severe cohort, we operate within 48 hours on those patients. And for us, the rationale is they're likely to have a longer ECMO course, and we would like to be aggressive and do the repair and give them that benefit. For patients that are in the moderate category who have an episode of pulmonary hypertension, those patients typically will have a short ECMO course, so we operate on those patients after we decannulate. And so far, that strategy has been working pretty well.
So anticoagulation on ECMO. So what centers are still using heparin or converting back to heparin for surgery in the audience? So most have moved to bivalve, and I can tell you that of the panelists, one is still using heparin, and several are on bivalve, and the others are making transition to bivalve. Is that correct? David Kays is using bivalve now, and what he thinks is that heparin is more bleedy. This is, quote, heparin is more bleedy and bival is more clotty. And Ina shared a nice hypothesis that bival is PTT assessed, and infants can often have a natural coagulopathy, so you might be reluctant to titrate up bival concentrations, and so perhaps there is more clotting on bival. I have burgeoning experience on bival and seems to be okay, but maybe more clotty like Dr. K's. He has some interesting management where he as he's coming off ECMO, he gets an echo looking for clots. He leaves the venous cannula in, and he will go and suck out clots even in the right atrium. Interesting, but we're not going to discuss that. And then, so what about muscle flap repair on ECMO? I think, there's limited engagement in that arena. Of the panelists, I think none were doing muscle flap repairs. How about in the audience? On ECMO, muscle flap repair, they're chopped, yeah. And I believe you've published on that or shared that experience recently. Sildenafil use, so an infant on ECMO, so who in the audience would not initiate sildenafil in their management? Anybody not use sildenafil in those cases? An infant with CDH on ECMO. Okay, so then when do we start it? Do we start it in the early few days? DeSola had a very rare case, went on ECMO late, that sildenafil predated the ECMO.
Yeah, so we usually we get echoes, like I mentioned, at birth the second day, and we tend to follow their pulmonary hypertension. So we'll put them on nitric, but if they still have persistent pulmonary hypertension when on nitric, we start the sildenafil fairly early on.
So we've been doing a slightly different approach. As I mentioned, we very rarely will use nitric pre-ECMO, but then once a baby is on ECMO, we've tried a number of different strategies and frequently would be doing nitric to come off ECMO, but we started dosing IV Flolan, epoprostenol, on our severe patients while they're on ECMO, and they're well supported, they don't get hypotensive, and that way they're fully loaded before it's time to decannulate. And we've had good results using that strategy. And then we would transition, once they're taking PO, to oral sildenafil.
So how about these other more advanced or less used agents, Bocetan and Flolan? Are any centers using these routinely in the severe CDH infant with persistent pulmonary hypertension, let's say 3 weeks of life, these two other medications?
We are.
Cincinnati? Others?
We'll use some at UNC. So, we basically start off, we'll maximize sildenafil if not, and if we're still having refractory pulmonary hypertension, we will consider Bocentin.
There's remarkably absent data supporting this, and as I can channel, well, as we all know, the pulmonary hypertension gets better with time, so it's very hard to measure effectiveness of these other medications and whether they are actually improving pulmonary vascular remodeling. I guess there's some animal evidence. Well, shoot, I think we have some time for some questions. If anybody has other questions to discuss. So by the way, the concept for this breakout, which this is a new concept for APSA, is to try to create a CDH club, which I know there are lots of CDH clubs out in the world, including a meeting that just met in Paris recently, but in the APSA setting, I guess. And it's obvious that there is significant variability in care, and there's very little evidence that helps us decide about best care. And as best I can understand is we have to look at institutional data where an institution defines their population of patients that's very well risk stratified to the best we have, whether it's with prenatal predictors as well as the first 24-hour predictors, defines their protocol of care, because there is good evidence to suggest that protocolized care is better than willy-nilly care, and then define their set of outcomes as best they can. And there are a number of places that have done that, and their results do seem to be better than other centers. There seems to be, and there's a lot of care variability, and we're just not sure which elements of the care are the best. David Kay's on the phone today. There was a lot of communication, but he got back to me like 2 hours ago, and we had a conversation. So he says that CDH care is about the lung, and they focus on optimizing the lung, and he doesn't care about the heart or the other organs, and that the lung's function is to get oxygen into the body and get CO2 out of the body, and that we need to treat the lung as well as possible. So his care protocols are all directed at lung pulmonary management and not at vascular issues, pulmonary hypertension. Questions? Beth?
Is anyone from All Children's here?
Oh, wait, is that mic working?
So Beth Romeski from Cincinnati. I actually went and spent a week with Dr. Kays last year because I was as skeptical as probably a lot of people in this audience are about the results and what he was doing and the numbers that were coming out and what patients were saying. And I left like floored because it's real what he's doing. I saw the prenatal images. I saw the patients he was taking care of. I saw the patients on ECMO, and like it's real. So like what he is doing there is not sort of smoke and mirrors. And I agree, he has a lot of like very hardline views about what's important and what's not important. And he's isolated himself from a lot of people because of that. But his outcomes are, I think, legit, despite the lack of a manuscript, which he still says he's working on.
And Beth, do you think it's fair to say, though, that he has a CDH unit?
Yeah.
And there is a director of the CDH care program there. And then he has supporting people that execute his direction.
It is a team that has a unified vision. So I think in the initial experience, it was 100% him. He took every call, he did everything. But I think now he has a team of people that are bought into it. He basically has a policy for, like, if you're covering call, these are the guidelines. Like, this is how we manage CDH. If you're going to go outside of these guardrails, it has to be escalated to like him or someone else if you're going to go sort of outside of what is typically how they manage the patients. So it is very regimented in terms of how they do it. But it is also like they're not stressed out. Like you'd be like, what's going on with that baby on ECMO? Like, oh, they're fine. Okay. Like I would have been like at the bedside, like, you know, checking 7,000 things, like, but they don't because they have a system, they trust the people, and it's working. It was interesting. So I think, George, you just went too, right? It was.
Just going to say it in a different way. Like, of course, protocols are important, but I think it's also really important. We all can't have a CDH center like Dr. Kay's, but to have a very unified team approach, so that which is well beyond just a protocol.
Right.
And so, you know, there's other centers also that get a lot of echoes. They focus on the heart. I do think pulmonary hypertension is real. Like, it's not just all about the lung, but nevertheless, they have a different approach. But if it's a unified, systematic approach where everyone is doing everything in a similar fashion, they have good results too.
Yeah.
So I think that's an important point. And I think, you know, it's difficult to do in many of our settings.
Agree.
Couple other questions or comments?
Hey, I'm Farouk Demary, I'm at Boston Children's, and just want to also had the privilege of, when I was doing an ICU fellowship, I spent 2 months with Dr. Kays in St. Pete, that was his fellow. One thing I think, because now what we try to do at Boston is trying to implement some of those practices to our center, which is hard. We don't have a CDH unit. No one else does. But trying to core out what are the key concepts, what are the key principles that can translate. And among other things, one of the things that has been trying to translate to our center is rethinking this pulmonary hypertension and rethinking the pulmonary vascular bed. Because one of the key concepts that they emphasize, which we're trying to emphasize as well, is offloading, as you mentioned, Dr. Milishka, the pulmonary vascular bed. And this concept that relative over-circulation of the lungs, if you have hypoplastic lungs, is what causes and begets more pulmonary hypertension. So key things that they use, which we're trying to implement, is absolutely no pulmonary vasodilator treatment until you are weaning ECMO, after your lungs have grown and the vascular bed has grown to be able to handle that pulmonary vascular flow. Is one of the key, I mean, because as a foreigner coming in and leaving, it's like, how do I translate this? And that's, I think, one of the key sort of brain shifts or mind shifts that happened when I was down there. So in addition to everything else, the systems-based things you're talking about, absolutely critical. I mean, you have to have a team, you have to have a system, but.
Thank you.
Thank you.
Jason.
Yeah, Jason Robertson, Cleveland Clinic. I trained with Dr. Kays for 2 years in fellowship. And, I would just stress that, despite the lack of a recent publication, everything is very well protocolized there. It came from, him doing this himself for a long time, but there's a very clear algorithm and approach that is applied to every patient. And that's part of the standardization of care that I think makes a difference. And, he does focus on the lungs. The lungs are the most important in that, if you beat up the lungs early to try and get better oxygenation or keep somebody off of ECMO, or you're hammering the lungs when they're on ECMO to try and get them off faster or something like that, you're going to cause iatrogenic injury that leads to long-term pulmonary hypertension. And so it's not that he ignores the heart and everything else, but he focuses on what's going to give a good long-term outcome. And so that's even part of his rationale in using VA ECMO, is that weaning off of ECMO, he'll gradually wean the flows. And the idea is that he's training the heart you're unloading the heart initially, but you're also training it to come off ECMO. And those transitions off are very smooth there. It's not like I've seen other places where you're trialing off ECMO and you're there like ready for the patient to crash, needing to initiate all kinds of other agents. It's a very smooth process coming off. And he leaves the cannulas in just in case you need to go back on for a few hours or so, but you never really do. I mean, it's very smooth. And his philosophy, like Farouk was saying, is we'll just start sildenafil when it's coming time to wean off ECMO to smooth that course. So, I mean, I think the pulmonary hypertension there is less a vasoconstrictive phenomenon and more related to the microvascular pulmonary bed, like Farouk was saying, and the hypoplastic vasculature, hypoplastic lung. It's an anatomic issue and really kind of a different type of pulmonary hypertension than, say, your PAH in adults. I think when you add too many vasodilatory agents early, you end up then giving more fluid or adding more pressors, and all of that compounds itself. The more you try and do, the more you end up causing iatrogenic problems. You're either creating too much edema in the lung or some other complication. And so I would just echo, things are very well protocolized there and followed very well, because he has his own unit with his own neonatologists and his own nurses and everything else. But there is a very clear protocol that works quite well.
Sounds like less is more. And I
He would
believe
agree with that, too.
David is of the Charlie Stoller lineage, though, so perhaps many of these concepts evolved from him and Jinhua, his neonatology partner at Columbia Presbyterian originally. Well, I think we're supposed to wrap up. We went over a few minutes. I really thank you guys all for your participation and attendance. And obviously, this is an unsolved problem and lots more to work on. Thanks so much.